Okay, this is video number 1 for Tests and Measures lecture number 4. We're going to start with special tests, okay, and then the second video is going to be physical performance measures. Now, we have already seen a few special tests when we did systems review, and I showed you early on how to do the vertebral artery test, okay, which was as simple as just having your patient turn to the right. I'm sorry, this person's turning to the left, okay? And really what that one was doing was testing the patency of the vertebral artery on each side. So that was a vertebral artery screening test. The other tests had to do with assessing the transverse ligament and the alar ligament. So I just want to show you arthrokinematically what is happening when you do those tests, because I was lamenting the fact that I didn't pull out the plastic spine when I showed you those tests before. And since they're technically special tests, I'm going to show you on the spine here, but I'm not going to do it again on one of my kids. So I want to refresh your memory here, okay? As you look at the atlas on the axis, okay, we know that the dens of the axis, okay, is anterior and is held against the anterior arch of the atlas by the transverse ligament, okay? So it prevents this atlas from sliding anteriorly or from sliding that way on this axis. So the special test that we did when the patient was supine and we took our hands on the occiput, because the occiput and the atlas travels with the occiput, and we basically created an anterior shear of the occiput on the axis to assess what the end feel feels like, okay? Obviously, we wanted very minimal translation to occur, because if a lot of translation occurred, it would mean that this dens of the axis wasn't being held firmly against this anterior arch of the atlas, and so the atlas would have been able to shear way more anteriorly, and that would have indicated some compromise of the transverse ligament test, okay? So that test, if you come down here, please, okay, was in supine, and we had my hands here underneath the occiput, and I generated an anterior force of the, are you close enough to see?
Zoomed in.
Okay. Because sometimes when you zoom, it's fuzzy.
It's
is
fine.
it clear? It's not? Okay. Then what we were doing is we were taking the occiput and the atlas and trying to shear it anteriorly in this direction on the axis, okay? This isn't going to move because it's plastic and it's bound together with a metal wire, but that's what that test was, okay? So that was the transverse ligament test that we did. The other transverse ligament test that we did, okay, so can you come and look from this way, is your patient was sitting. This is the sharp purser test, where we took the patient's neck and we brought them into about 20 to 30 degrees of flexion. We're stabilizing here on C2, and then through the patient's forehead, which you can imagine is here, we were taking the occiput and the atlas and trying to shear it posteriorly. What you should feel when you do that is almost an immediate posterior shear of this C2 spinous process that you're monitoring, okay? Right, that's all I want to say about that. If there is an excessive amount of posterior translation, or there's posterior translation and then you don't feel any movement posteriorly of C2, then theoretically the atlas and the occiput had already sheared forward because of transverse ligament tearing or a rupture, and by doing this motion you have essentially relocated it, okay? But again, the test motion is a posterior shear of this occiput and atlas on C2, so in that direction, which for that test, we're assuming that if there was a rupture and that if you're actually able to translate it and you don't feel the axis try and go with it, that there might be some compromise of that transverse ligament. And then, you can stay there. Can you still see this?
Yes.
We have the alar ligaments, which go from the dens up to the occiput in that direction, but way deeper in there than I can get my fingers, okay? Which we tested by side bending the occiput, okay, We know that with side bending, that rotation and side bending are coupled. So if I rotate the head to the right, I should feel right rotation of C2. And with right rotation, remember the rotation is named based on where the front of the vertebral body is facing. So that's right rotation. Right rotation, spinous processes move to the left. So to test the alar ligament, okay, on the right side, you side bend to the right, and you should feel right rotation, or an immediate rotation of that spinous process or movement of the spinous process to the left. Okay, actually, sorry, this right side bending is going to check the left alar ligament. Left side bending is going to check the right alar ligament. Okay, so left side bending, we should feel spinous process move to the right to indicate that it has gone with the occiput in C1 and has also rotated in the same direction. Okay, so that is your alar ligament test. Okay, glad I got to review that. Okay, special tests. Okay, so Ethan, come back. Okay.
Back in the spotlight.
Uh-oh, it looks like part of my spine came off. We'll figure that out.
I can't be good.
That's not good. Okay. All right, so now our first test is called the flexion rotation test.
Wait, do you laying down?
Laying back. First test is the flexion rotation test. This is going to look just like the passive physiological intervertebral motion we did for C1, C2 rotation. We also looked at C1-2 rotation when we did active range of motion, except that time we side bent and then we rotated. So they're just locking mechanisms for the mid to lower cervical spine. But in this case, he would conceivably be a patient who came in with a headache.
I have a headache.
Okay. And I want to target his C1-2 level to see if rotating at C1-2 provokes his headache, brings on a headache if he didn't come in here with it, but he's been complaining of them, or if he has a headache, does it make the headache worse or does it make it better? And then I'm also looking at the range of motion. If there's a loss of more than 10 degrees of rotation in either direction, then the test would also be positive, okay? But really a positive test has to do with whether or not it has an effect on his headache, assuming the headache is of cervicogenic origin, meaning that it is a headache that is being produced by his upper cervical spine. Okay, so come back towards me a little bit. There you go, okay? So you're relaxed. I'm gonna bring him up into maximal flexion of the cervical spine, and I'm gonna rotate his head. I'm looking at his range of motion. If he has a headache, I'm gonna say, does that increase it, decrease it, or does it stay the same?
No, I'm gonna say it decreases.
It decreases.
Makes it better.
Oh, good.
Does that mean I'm curable?
It does.
Yay.
And then in the other direction, I'm making judgment about his ranges of motion. I'm inquiring about his headaches to determine if that flexed and rotated position has an effect on his cervicogenic headache. If it does, that is what we will call a positive test. Another headache test that we have, okay, I'm going to have you turn over on your stomach.
Yeah.
Flipping around here. Okay.
Back to the face hole.
Back to the face hole. And you're going to lay on your belly. Okay. Now, this is going to look just like the CPAs and UPAs that we just did, but instead of doing, below C2, 3 and down, now we're going to come up to the occiput. And we're basically going to do a central PA to the atlas, and then we're going to do a UPA at the C1-2 level. Okay, so the way we're going to find that space, and I've mentioned a couple of times, and I want you guys to drill this into your heads, is that if you palpate the external occipital protuberance, and you stay central, and you sink down, you move inferiorly, the first spinous process that you feel is C2, okay? That space in between is the posterior arch. It's an empty space, it's a squishy space, okay? Okay, so you can see, let me go back. So the squishy space is basically that space between the occiput and C2, and conceivably if you were to do a central PA, in that space, you would be doing a PA force to the atlas. Okay, and that's exactly what we're going to do. Whoa, this person's having issues. Okay. Oh, I see. Is that what was poking you? No wonder that was uncomfortable. I'm sorry. Okay.
No, this is further down the back.
All right. So what we're going to do with this one, so here's the external occipital protuberance. You walk your way down, you find C2, and you come back to the squishy space. Okay? And then what we're going to do is we're going to drop a thumb in that squishy place, and then our dummy thumb, and we're going to do a PA spring test. And we're going to ask him, oh, patient who has the headache at this moment, does that increase or decrease your headache? Or does it not have any effect on your headache? Or if you didn't have your headache, but you've been complaining of headaches, does it provoke it? Okay, so that's the central one. A unilateral, you're going to put your fingers along this nuchal line here. Okay, so all 4 fingers, not your thumbs, okay, lined up here. And then you're going to come out to where your pinkies are. And then you're going to mark where that is mentally. And then you're going to put your thumb there. And then you're going to do a unilateral PA. So you can see that I have made my way out to the lateral mass of C1. So you line up your fingers next to each other along this suboccipital ridge. And then you're going to replace your pinky with your thumb. And then you're going to do a unilateral PA. And you're going to inquire about the patient's headache and what effect that UPA has on the headache. You keep trying to get up. I'm not done with you yet.
Denied.
Denied. Head back in the hole. Now, so on him, I'm going to palpate that suboccipital ridge. Okay. I'm going to find C2. So there is my first spinous process. So that's the external occipital protuberance. Here's a squishy space. Okay. I'm going to sink through the tissues. And then I'm going to do a straight PA spring test. And I'm going to say, how does that feel for your headache? Does that make it feel any better? Does it make it worse? Okay. That is your central PA. Now,
I'm going to go with neutral on that
it's going to go with neutral.
Nothing happened.
Nothing happened. Well, you haven't been complaining of headache, so I wouldn't expect it to be painful unless there was some kind of dysfunction going on there that we don't know about. Now, I'm back to the nuchal line, okay? I'm lining up my fingers. Here's my pinky. I'm going to put my thumb in the squishy space just where the pinky was, and I'm going to do a unilateral PA, okay? So I'm on the lateral mass now of C1 doing a posterior to anterior spring test to assess whether or not it provokes the headache that he's been having. And if he has a headache, does that make it worse or does it make it better? Now, if he told me that it felt better, I'd probably stay there and do some oscillations. I know you guys know what oscillations are because I know you have had your joint mobilization kind of introduction. We're going to talk a little bit more about that. But I would come back and use that as a mobilization. Okay, so that was another special test for headaches. Now, since I am here, and I've mentioned before when we did central and unilateral PAs as a way to, we did it with passive accessory testing. And I also, in that case, we were looking at what the end feels felt like. You can also use central PAs and unilateral PAs to try and identify involved segments. Okay, so if your patient had neck pain and you wanted to try and implicate a particular region of the neck or a particular segment, you could come through with central PAs and inquire when you do that spring test on those on each segment, does that have an effect on your pain? Either does it produce your symptoms or produce your familiar symptom, or if you're having symptoms at the time, does it make it feel better or does it make it feel worse? If it makes it feel better, then you might then stay there and you then right there on the spot, you turn it into a treatment and you can turn it into an oscillatory joint mobilization. Okay, so central, unilateral, we just did those with the passive accessory testing, so I'm not going to show you that again. Just understand that technically, in addition to using it as a spring test for accessory motion, you can also use it as a provocation test to determine involved motion segments. Okay, now we are going to sit up. Sit up over the edge of the table, please. Okay, now, totally switching gears from talking about
Right
even
on.
just some accessory testing. You're good, you're just gonna sit. Let's say that Ethan came in with neck pain and he's like, sometimes I get this shooting pain that comes out into my arm and it lasts for a couple of hours and it really bugs me. Okay? So in my head, my red flags are saying, ooh, I wonder if there's any element of radiculopathy. Okay? And when I'm talking about radiculopathy, I'm talking about spinal nerve root irritation. We know those spinal nerve roots exit the spinal canal through the intervertebral foramen. So theoretically, if I was to put his neck in a position that would close down the foramen, I might reproduce his spinal nerve pain and reproduce his concordant upper extremity symptoms. Okay, so this first test is called a Sperling's test. And what I'm going to have him do, ideally I would lower this table, but I think I'm okay here. Okay, I'm going to choose his right side, and let's say he came in with right radicular symptoms, but he's not having them right now. Okay?
Obviously.
So, what I'm going to say, so Ethan, I want you to go ahead and side bend your head to the right. So bring your right ear towards your right shoulder. Okay? And then I would inquire, I say, does that reproduce the symptoms in your arm?
No,
Say
but
no.
it make my arm feel a little tingly. Just a little bit.
Seriously?
Actually, yes. Just a little tingle.
Okay, I'm going to see if I can make it worse.
Oh, no.
Jeez.
Okay, tuck your chin in. Very good. Side bend your neck this way. Okay. That's still making your arm tingly?
A little bit. Less now.
Less now.
I don't know. Maybe it was something random.
Let's try
Maybe
your
you're
other
having,
side.
maybe I'm having pseudo symptoms.
So-
You made me believe something.
That's called psychosomatic symptoms.
Something like, oh,
This child
intelligence.
is very prone to psychosomatic symptoms.
It was probably nothing.
It probably was, but in real life, if he had come in and had complained of symptoms in his right upper extremity, but he didn't have them at the moment, and then I had him actively side bend, and he said, oh, yep, there it is, then I'm done with my test. There is no reason for me to do the second part of the test, which would have been to come above him and apply some compression. So I'm not going to do that, but I'm going to test his other side. Okay, just for kicks, because I want to show you the compression. I don't know whether his right symptoms right now were psychosomatic or not, but if just in the event that they weren't, we're going to do his left side. So bring your left ear towards your left shoulder. Does that reproduce your familiar
No.
symptoms? It doesn't. No, so stay there. And now what I'm going to do, I'm going to make a tent.
Hang on, I'm feeling dizzy. No, I feel like it's like the blood sugar thing. I need it.
Okay, he's hungry.
I'll get it later.
Okay.
Christ.
Stop. I have really sensitive boys.
Just
No,
one.
it's just me.
Side bend. And then I'm going to tent my hands. I'm going to come here. And then I'm going to apply a gentle but firm compressive force straight down this way. And I'm going to say, does that reproduce your symptoms?
No.
And he says, no. Okay. So all I've done then is I have just further closed down the foramen on that left side. Okay? Okay. So if that had reproduced his symptoms, then I would have called that a positive test. If I had him just side bend and it reproduced the symptoms, then I would have still called it a positive test, but I wouldn't have done the compression. Now, let's say he had symptoms going on in his left upper extremity at the moment. I could do the opposite, and I could come here and I could lift up on his head and provide him with a little bit of a distraction to see if it decreases the symptoms in his left upper extremity. You okay?
No, I gotta go get something.
Okay, go.
Okay.
No, don't stop it yet. We're gonna be good.
Christ.
We're gonna keep going here.
I'll figure it out. I'm sorry.
He apparently hasn't eaten enough, so that I don't have to go back through all of this, and we're gonna do all of these again at some point. I'm gonna show you on my plastic spine. Hey, send Luke down here, Ethan,
Oh my god.
and tell him to hurry up. This is fine. Sorry, students. Yep. I'm bringing you another patient. Last patient was about to fall out from hypoglycemia. Come lay on the table, please. And turn on your back. And don't be crazy silly. This is Luke. He's my youngest.
Hi.
You say hi to them, not
Hello.
me.
Are you about to smother me? Please don't.
All right, I'm not starting this again. Lift up your head.
We're 20 minutes in.
We are 20 minutes into this video. All right, so this next one is a cervical spine distraction. So you just saw me do it with Ethan where I did it in sitting. So that's an easy way to do it. I'll have much more control over this if I do this with my patient in a supine position. Scoot back towards me. Keep coming, a little more. Okay, another inch or so. Okay. And you're probably like, you're gonna do this test on an 11-year-old? Yes, I'm just gonna do it gently. And none of these tests are, you know, it's not gonna hurt a kid to do this. So I wouldn't do it if I thought I was gonna hurt this cute little face. Okay? So what I'm gonna do now to create a distraction is, and when I say distraction, so the Sperling's test with the compression, those were about closing down intervertebral foramen. When I do a distraction, like I just did in sitting and like I'm gonna do now, they're designed to separate cervical vertebrae, so in effect it will be opening those intervertebral foramen. So I'm gonna put one hand under his occiput and then the other hand on top of the other hand, okay? You get to relax though. Don't look so scared. I'm not gonna hurt you.
Much.
Okay. So now I would also have this table a lot higher. Again, I'm limited by not having a high-low table at home. Okay. So I'm going to have both hands under here. Okay. Under the occiput. My other hands are going to, or my thumb is going to come around here and just sort of rest on the mastoid processes. Make sure you don't dig your thumbs into the front of their neck because they'll feel like you're choking them. Okay, so I have, if you can see, Julian, my feet are in stride because my distraction force is going to come from a weight shift. I'm gripping and anchored on his occiput. Okay, I'm also going to provide a counter pressure from my shoulder on his forehead, and then I'm just going to shift my weight. You feel me like I'm making you E.T.? A little bit?
Yeah.
My hair in your face?
Yes.
Yeah. Try not to let that happen, but he's my baby, so I can do whatever I want. Okay? And also don't be right in their face. Okay? So I have my face out to the side. Patients don't like it when you breathe directly on them. So I'm doing a weight shift and providing a distraction. And I'm going to hold it there and I'm going to say, hey, Luke, those symptoms you had in your left arm, do they feel any better? Or do they feel worse, or is it about the same?
They feel the same.
Feels the same. I'm going to hold it a little bit longer. Because sometimes you have to give it a little bit of time to react. How about now?
Better.
Is it better? Great.
Yeah.
Okay, and then I'm going to gently release the traction. So if you can eliminate or pull somebody's symptoms out of their arm just by doing a distraction of their cervical spine, then you know that somewhere you're decreasing pressure on the spinal nerve roots. Okay, so that is your distraction test. Now, the last test we're going to do, I want you to sit up over the edge of the table, please. Facing Julian. This last test is going to be for a potential elevated first rib on one side or the other, okay? Which can happen a lot. It can happen in car accidents. It can happen in people who just live with their shoulders approximating their ears. What is going on? Stop. Don't make him laugh. And now we got the dog going. I really hope that you guys find this entertaining as well. Okay? So a lot of different reasons that you can have an elevated first rib, okay? Most of the time, honestly, it's a postural issue, or people who do a lot of overhead work, overhead sports, okay? So what we're gonna do to test the right side is I am going to maximally rotate his head this way, and then I'm gonna side bend. Then we're gonna side bend your ear this way. Don't move the rest of your body, okay? So we side bend, and then we rotate to the opposite side and then side bend toward, okay? If somebody has an elevated first rib, what happens is by rotating him all the way that way, the transverse process of C7 kind of swings around this way, and then you try and side bend like this. And so if the first rib is elevated, that transverse process is going to bump into that first rib, or that first rib is going to block side bending of the lower cervical spine. So that's kind of the gist of this test, okay? And then we'll check the other side. So we rotate, don't rotate your body. So I'm going to rotate him this way, and then we side bend. See, he feels fine. If he had an elevated first rib, the side bending range of motion would be limited, but he would also it would feel like a bony block to motion, okay? Like something was blocking the side bending, and that would cue you into, I wonder if there's a first rib issue going on. When we get to the thoracic spine, I'm going to show you other ways to evaluate the first rib, because I would probably come back and try and treat it. Evaluate it more specifically and then treat it, and you'll learn how to do that when we get to the thoracic spine. And that concludes our special tests. Thank you for filling in
Nothing. Oh, okay.
for your brother.
Yay.
Okay.